Breech birth is a relatively rare phenomenon, with only 3 to 4% of full-term births being breech and 10% of births at 30 weeks occurring breech. However, there's significant maternal and fetal morbidity and mortality associated with breech, and therefore it's an important skill understanding to have for paramedics, enabling them to safely identify presence of a breech birth and then facilitate that pre-hospital delivery of a breech if required to do so. There's three main types of breech, the most common being frank breech, which occurs in 65 to 70% of these births. As you can see, both feet are located up towards the shoulders of the infant. The second most common is the complete breech. As you can see here, the knees are flexed with both legs crossed across the newborn. And the third is a footling breech. This is where one or both of the legs may be extended and away from the infant's body. As always, a key component pre-hospital is going to be a thorough danger assessment, and this includes proper and adequate personal protective equipment. In this instance, a gown, eyewear and gloves should be considered and worn by the clinician or paramedic. In this video, there's been a restriction on a quantity of PPE, so please assume that all clinicians are wearing this PPE demonstrated. It's then going to be crucial for paramedics to determine whether the breech birth is in fact imminent. If it's not deemed imminent, then all action should be taken to transport the patient to an obstetric facility in order to facilitate an in-hospital breech delivery. However, signs of imminent delivery will include increased frequency and severity in contractions with an urge to push, membrane rupture, bulging of the perineum, or an appearance of presenting parts through the vaginal canal. Some serious complications of breech delivery include fetal hypoxia, a prolapsed cord, head entrapment, meconium aspiration, postpartum hemorrhage, and inversion of the uterus. Incorrect manoeuvres may also cause significant morbidity or mortality. This may include spleen and liver damage of the fetus, fractures, soft tissue injuries, cerebral hemorrhage if delivered too rapid, or cervical and brachial plexus injury. It's also going to be critical that paramedics are prepared for a neonatal resus if required to do so. So having the correct, adequate equipment set up and prepared is going to make this situation far less stressful for the paramedics and also the mother. Breech delivery is largely a hands-off procedure. So once the buttocks have entered the vagina, tell the woman that she can push with contractions, but let the buttocks deliver until the lower back and then the shoulder blades are seen. Gently hold the buttocks in one hand, but do not pull the child out. If the legs do not deliver spontaneously, gently push or flex behind the knee, bend the leg, grasp the ankle and deliver the foot and the leg, and you may need to repeat for the other. If the arms are stretched above the head or are folded around the neck, the love sets maneuver will need to be performed. Hold the baby by the hips and turn 180 degrees, keeping the back uppermost and applying some gentle downward traction at the same time, so that the arm that was posterior becomes anterior and can be delivered under the pubic arch. Assist the arm by placing one or two fingers under the uppermost part of the arm. Draw the arm down over the chest as the elbow is flexed, with the hand sweeping over the face. Utilize a towel to ensure that there's adequate grip on the baby's buttocks and hips. However, ensure you do not hold the flank or the abdomen to prevent kidney or liver damage. If the baby's body cannot be turned to deliver the arm that is anterior, first deliver the shoulder that is posterior. Hold and lift up the baby by the ankles, move the baby's chest towards the woman's inner leg. The shoulder that is posterior should now deliver. Free the arm and the hand. Lay the baby back down by the ankles. The shoulder that is anterior should now deliver. It's then time to deliver the head. Deliver the head using the adapted MSV maneuver. Lay the baby face down with the length of its body over your forearm and hand. Place the first and second fingers on the baby's head and the baby's cheekbones and flex the head. Use the other hand to hook the baby's shoulder with the index and ring fingers, with the middle finger on the baby's occiput. Gently flex the baby's head towards the chest to bring the baby's head down until the hairline is visible. Pull gently to deliver the head. Raise the baby still astride the arm until the mouth and the nose are free. Deliver the baby onto the mother's abdomen for skin-to-skin contact. During this manoeuvre, often an assistant will be required to push above the mother's pubic bone, suprapubic pressure, as the head delivers. This helps keep the baby's head flexed. It's also beneficial if the mother is in the McRoberts or knees to nipples position. Care of the newborn or postnatal care then commences. Thoroughly dry the newborn, wiping the eyes, and assess the newborn's breathing. If the newborn is crying or breathing effectively, leave the newborn with the mother. If the newborn is not breathing effectively, immediately commence newborn resuscitation. Ensure the newborn is kept warm and heat loss is minimised. Assess neonatal and maternal observations with an APGAR being performed at 1 and 5 minutes. This should include a heart rate, respiratory rate, temperature, muscle tone every 15 minutes. There's evidence to suggest that late cord clamping, which occurs at 3 to 5 minutes, is recommended for all births, whilst initiating simultaneous essential neonatal care. Immediate cord clamping less than 1 minute following birth should only be performed if the newborn is asphyxiated or needs to be resuscitated. Some mothers will request that the cord remain intact with the placenta attached. This request should be respected by paramedics and transported appropriately. When cord clamping does occur, clamps should be placed at 10 and 15 centimeters from the newborn. The management of the third stage of labour then commences. Promote maternal production of oxytocin by providing a safe and warm environment with uninterrupted skin-to-skin contact between mother and baby, encouraging early breastfeeding. There's also evidence to suggest that administration of oxytocin early decreases rates of postpartum hemorrhage and is beneficial for mothers. Observe for signs of placental separation. This may include the uterus rising in the abdomen, the uterus becoming firm, a fresh trickle of blood, and lengthening of the umbilical cord. To deliver the placenta, assist the mother to birth the placenta by her own efforts. Encourage her to adopt an upright position, bearing down to expel this placenta, or guard the uterus by placing one hand suprapubically and applying steady, controlled cord traction until the placenta is visible. Retain the placenta for visual inspection by the midwife and/or obstetrician before completing a fundal assessment. If the uterus is soft, massage the fundus until it is firm and central. Consider asking the mother to pass urine, as a full bladder can inhibit the contraction of the uterus. Fundal massage is only to be performed following the delivery of the placenta. If the uterus is firm, do not massage the fundus, as this may cause further bleeding and pain for the mother. This concludes pre-hospital breech delivery. Definitive care will require timely transport to an appropriate obstetric facility, with pre-notification of the birthing unit, often liaising with an obstetrician or midwife on duty. Paramedics should regularly perform newborn and maternal observations during transport, monitoring for any deterioration of the newborn or of the mother.